I'm gonna set this up
Yeah, my parents used to sell Iowa, and my dad sells Maine and Argentina. So
this back here, so it's not. Yeah.
we got married.
And just to let you know, there's a little bit of a delay because it's going to move first. Okay. Where do I advance on the big one? Yep, you can advance here. I'll get this out of the way. I just wanted to make sure. Do you want to maybe just do a quick snap right there for a few minutes?
Chapel Hill.
Can you hear?
I think that was good. Just don't wear it.
Yeah, right.
It's going on my laptop, so I'm not. Just making sure we're good to go on the live stream, so it's a little bit of a delay, but we're getting things ready here.
Yes, feel free to keep getting food and mingling. We're gonna start in about 5 minutes. We'll just get the live stream going and then we'll get going. What does it look like on yours?
So it is going.
Good chances. Yeah, you got put in that many chips in the pot. You don't want to
She started with the billing change.
yeah, train for as long as I can. 250 figured out. Yeah.
Yep, so it's just my same page. These comments are off to the side.
Yeah, right. Nope. Yeah.
So it's not live stream, so I'm live stream. Yeah, I have a cell phone. Your call is on.
The only thing I can think of too is if you just would copy the Zoom link into this chat. And then people just watch it through. I don't know. University. I think they can, I just don't know. So that way, if this is what they say, you will get it.
But there's so many things that I
I think there's usually a limit to how many people can watch on Zoom, but I think it's like 500 or something.
Yeah. No, I can tell. I'm gonna like.
So we obviously have people interested. Okay. But it's just, you can see them.
Yeah.
They're all, and she said, being everyone ready, we're starting to review this. Thank you. I just think if everyone's watching, she said it's not way to get around it. In other words, is it raining? Oh boy. Which is always, she's recording on Zoom, so she can always upload it to YouTube later. So this can still be uploaded. that was a.
Yeah, he's pretty good at troubleshooting stuff.
Yeah. Let me go into my email, put the link. Where do you live? Do you fly in for the event? Oh, wow. So a little trip. Have you been here before? I have. Okay. Do you do a lot of talks?
I mean, I haven't done any since COVID. I had been doing more. I was trying, I think, fall of 2019 was the last time. I feel like I did a lot of traveling across, and it's just starting to pick up again.
So just getting back with the swing of things.
Yeah.
Oh, hopefully we can get this thing like figured out.
I like it. No, I like it. Traveling. Having a little time to myself.
That would be nice. That's perfect. Just getting back with you. There's no link on us. So we're.
It's good. It's like perfect atmosphere.
We should have everybody join.
I was very grandfather. And I'll meet up that. Yeah. She's probably a handful of hands are out. So we got to work it out.
I have like a
Oh, yeah.
okay, perfect. That's
Oh, I think it will be. That works perfect. And I think I should appear in the corner now, or is.
Yep, it's right up there.
Yeah.
So that's. I'm gonna head out here and just double check again, but thank you.
All right, we got it. Okay, we got the live stream working. So hopefully everyone can hear me. So we are so excited to welcome you here to Wegner Library this evening for our first Speaking of Health event. And we are truly thrilled that you're here, both online and in person. Our vision for this series was to bring as many people together from as many different communities as possible in order to have important conversations about health and life. And here we are. My name is Anna Simonson, and I have been working with many people over the past several months, including the two other individuals on this grant with me, Dr. Pete Hasing, who's right there, and Ellie Schellinger from the DeGroote Center for Bioethics, and I don't see Ellie here yet, to make tonight happen. Nothing like this happens without the help of many people. And first and foremost, we would like to thank the South Dakota Humanities Council for their generous grant that allowed us to envision this program in the first place. Without their support, we wouldn't be here, so thank you. I also want to thank the Dean of Libraries, Dan Daly, who is right over here, who is deeply supportive and cares very much about finding innovative ways to connect and serve all patrons to the best of the library's ability. He works tirelessly to make the university libraries places of knowledge and excellence, and we are very grateful for his leadership. Shelley Bassick is the director of the Wegner Library, and she is the one doing the live stream right out there. And without her support and passion for healthcare and seemingly endless energy, this event also would not have happened. Last but certainly not least, the Sanford School of Medicine, especially Doctors Tim Ridgway and Mark Beard, are wonderful supporters of the health humanities, and we are very grateful for their encouragement of this particular program. A few housekeeping things before I introduce our speaker. There will be a 15-minute Q&A at the end of the talk, so we invite you to stay and ask questions. There are no questions that are too big or too small, and we really do welcome all of your questions, so please do ask.
Also, the book we are discussing tonight is for sale just outside of this classroom at the table in that back corner. So please visit that table and consider purchasing Dr. Buchbinder's book if you haven't already gotten it or read it. Lastly, we would be very appreciative if you would take a minute at the conclusion of the talk to fill out our evaluation form for the South Dakota Humanities Council to let them know your thoughts about this event. So you can either fill out the paper form, which we have on the table over here, the info table, or on that paper form, we have a QR code that you can scan on your phone, which will take you to the online version of that form, and you can do it that way too. There's a box. If you do choose to fill it out by pen, there's a box for you to leave it at. Our next speaker for this series will be here in December. So I just want to give a little shout out to that. December 20th, Sam Keene, a South Dakota native, who will be discussing his most recent book about medical history and medical ethics called The Ice Pick Surgeon. More information can be found on the info table there. Also, lastly, there are sheets for you that I think went around the room for you to put your email addresses. You can stay informed this way about Speaking of Health events, and you might also win something. I'm not making any promises, but it's possible if you do give us your email address. Okay, we are honored tonight to have Dr. Mara Buchbinder with us from the University of North Carolina, Chapel Hill. Dr. Buchbinder is a medical anthropologist. She is the vice chair of the Department of Social Medicine and an adjunct professor of anthropology at Chapel Hill. She is also a core faculty member in the UNC Center for Bioethics. Dr. Buchbinder has broad interest in cultures of health, illness, and medicine in the United States. Her recent work focuses on how patients, families, and healthcare providers navigate social and ethical challenges resulting from changes in medical technology, law, and health policy. She is the author of several books, including All in Your Head, Making Sense of Pediatric Pain, Saving Babies, The Consequences of Newborn Genetic Screening, and the book she'll be discussing tonight, Scripting Death, Stories of Assisted Dying in America. So please help me welcome Dr. Buchbinder.
Thank you so much for the warm welcome. It's really an honor to be here tonight and to speak with you all. So I'm going to be sharing with you some of what I have learned through my anthropological research on the implementation of Vermont's medical aid in dying law. And I conducted that research between 2015 and 2017. And through the course of that research, I conducted hundreds of stories about the desire for control at the end of life. And those stories have really helped me to rethink some of the dominant public and media narratives around medical aid in dying. And that's what I want to talk with you about tonight. So I want to start just by acknowledging my funding support from the Greenwell Foundation and the National Science Foundation, as well as my university. And then also to thank my wonderful research assistants who have helped with this research. And I'm going to start now with two case vignettes. The first is about a woman that I call Frances, and all of the names that I'm going to use tonight are pseudonyms. I had the pleasure of meeting Frances in her home about 5 years ago now. She was in her 60s and she had been living with ALS for several years. And I walked into her home, which was this beautiful rustic log cabin that she and her husband had planned to retire to. And she was sitting on the couch waiting for me, and she handed me this note. And I'm going to read it to you, but she had written this out because the ALS had so severely impacted her speech by this point that she was primarily communicating via iPad. So the note said, I've been a critical care RN 1975 to 2015, seen many patients die on respirators, tied down, pleading eyes as I give meds to settle them. But who knows what they were thinking trapped like that, families coming and going, exhausted. In acute care, some patients would never go through what was going to happen to them if they had the choice. But once that starts in that setting, there's no going back. They die attached to tubes, feedings, incontinent, no communication, tears sliding from corners of eyes. Many patients and families need to have this option. It's our bodies and lives and should always be our choice. When and how we die is our right. I would advocate for my patients when no hope at all, but would be endless discussions with their team of doctors, then each specialist weighing in, then palliative care, then family meetings, and on and on. But the one person left out is the one dying slowly who was never given a choice. And Frances went on to hasten her death using medical aid in dying a couple of weeks after we met. This next email is, this next case concerns an email that I received from a prospective study participant in April of 2017, and I'll call her Margot. She had heard about my study from a hospice volunteer that had helped take care of her husband as he was dying. And her email read, "My husband died 1 year ago. He suffered from a chronic disease for which there was no cure. He very much wished to have a dignified, pain-free death on his terms and was hopeful that Act 39 would make that possible. We were shocked to learn that our local hospital prohibits its physicians from participating in Act 39. An exhaustive search elsewhere in Vermont was no less promising, as we were informed by several physicians that heightened scrutiny in Vermont made them reluctant to participate in Act 39. At a time when I should have been comforting my dying husband, I was desperately trying to navigate Act 39 on his behalf. I regret that it took me from his bedside. I think Vermonters would be shocked if they knew how inaccessible Act 39 is." And when I interviewed Margot in her home a couple of months after this, she told me, "I feel really badly that Vermonters are under the illusion that Act 39 is available to them. And it really wasn't," was my experience. So what I want to suggest to you today is that these two vignettes represent two distinct faces of medical aid in dying. And Frances's story is the one that tends to be emphasized in advocacy discourses, where we have a terminally ill patient who was desiring to control the timing and circumstances of her death and requested assistance from a trusted physician who would accede to the patient's wishes. Some of you might recognize this woman. This is Brittany Menard. In 2014, at the age of 29 years old, she sort of became the new face of the assisted death movement in the United States when she moved to Oregon and established residency there to make use of the state's death with dignity law after being diagnosed with terminal brain cancer. But one of the goals of my research has been to bring to the foreground the gaps between these advocacy narratives and some of the lesser known narratives about what actually happens when this practice of medical aid in dying is put into practice. And so this is a picture of Judy Dale, and her family sued the University of California, San Francisco Medical Center in 2016 for allegedly misleading Dale into thinking that they would be willing to prescribe lethal medication under the state's medical aid in dying statute. And in my view, both of these stories, as well as those of Frances and Margot, are really central to understanding medical aid in dying as a new medical frontier in the United States. So the goal of my talk today is to foreground some of these previously hidden narratives. My plan for the talk is as follows. I'm going to start with some background on medical aid in dying in the United States and tell you about my research methods. And then I'm going to tell you about 3 previously hidden narratives about medical aid in dying. So the first is the access narrative. And the dominant narrative surrounding access to medical aid in dying is that the legal status is the main impediment. So, for example, in South Dakota, you may wonder, why shouldn't South Dakotans have access to this option that their neighbors in Montana or Colorado do? And this narrative suggests that once medical aid in dying is legalized, patients will have access to this end-of-life option. But my research in Vermont really suggests otherwise. So I'm going to show you tonight how patients encountered a range of barriers to accessing medical aid in dying in the aftermath of legalization. The second dominant narrative that I want to explore concerns the role of physicians in participating in medical aid in dying. And according to this narrative, participation is an all or nothing proposition. Physicians are either for it or against it. They will prescribe or they won't. What I found instead is that physicians really revealed a wider range of stances toward medical aid in dying. And then finally, the dependency narrative suggests that terminally ill patients pursue medical aid in dying because they don't want to be dependent on others for end-of-life care. And from this perspective, medical aid in dying might look like an act of radical individualism. Given this narrative, I was somewhat surprised to find that medical aid in dying is actually an extraordinarily relational practice, one that fosters new forms of sociality, even as it permits people to avoid certain types of dependency. And then finally, I'll conclude with some brief thoughts about how these new narratives can help to reframe old debates about the right to die in the US.
Okay, so just to set the stage a little bit for you, the legalization of medical aid in dying, which you may also know by the name assisted suicide. These are different names around the same practice that often signal the speaker's political stance toward the subject. I've opted to use medical aid in dying as opposed to assisted suicide because advocates really are offended by this notion that that this practice is similar to suicide because they want very much to live, but they're terminally ill and they won't live. So the legalization in the US has proceeded at the state level, beginning with the passage in 1997 of Oregon's Death with Dignity Act. And in that same year, 2 Supreme Court decisions rejected the view that there's a constitutional right to die with assistance from a physician, but they left the door open for individual states to authorize the practice. The number of permissive jurisdictions is now 11, making this end-of-life option in theory available to a little more than 1 in 5 Americans. Montana is a different, lighter shade of blue on the map here because in Montana, the practice was legalized via a judicial decision, but there's no regulatory statute in place. And so it looks a little bit different in Montana. And it's worth noting, this is really a rapidly shifting landscape. The New Mexico bill was most recently signed in spring of 2021. Many other states have considered legalization in the last year or so. And several states that have existing laws on the books have recently introduced new legislation to modify laws and eliminate some of the safeguards. So the new trend is toward eliminating some of the waiting periods and doing other things to try to make access a little bit easier for patients. Data from the last 20 years, really 25 years now in Oregon, suggests that most people who pursue medical aid in dying are not motivated by concerns about pain, but instead it has to do with concerns about a loss of autonomy and dignity at the end of life. So patients seeking assisted death are really seeking a desire to control the time and circumstances of their death. Vermont's law is the Patient Choice and Control at End of Life Act, and that's the law that I focused on in my research. That law was passed in 2013, and at the time it was the 4th state to legalize medical aid in dying. And I have a picture here on my slide of former Governor Peter Shumlin signing the bill into law. At the time that I started this research, Vermont was the state that had most recently legalized. And that was the main reason that I decided to focus on it. I was really interested in understanding what happens when these laws are new and their practical significance is still being understood on the ground. They're still being implemented on the ground. Vermont was also the first state to utilize the legislature as opposed to the courts or a ballot initiative. And Vermonters are very proud of the grassroots mobilization that helped to accomplish this. The medical and legal requirements are largely identical to those that have been in place elsewhere in the US. The law permits physicians to write a lethal prescription to a mentally competent adult patient as long as these requirements are met. So there has to be a terminal diagnosis, a diagnosis that's expected to result in death within 6 months. There have to be 2 voluntary oral requests spaced 15 days apart. The diagnosis and prognosis have to be certified by a second physician, and the medication has to be self-administered. And all of this is designed to ensure that this practice is voluntary and that patients are not coerced against their will into choosing an assisted death. Participation for physicians is also voluntary. In January of 2018, the Vermont Department of Health released a report about the utilization of Act 39. The short name of the law is Act 39, and people in Vermont commonly just call it Act 39. So these are sort of the statistics about how the law was used in its first 4 years. So you can see the frequencies are pretty low. Vermont is a small state. It's got a population just over 600,000. In that time, paperwork for 52 patients was filed, and most of these were cancer diagnoses. And 60% of the patients had died as a result of ingesting the medication at the time the report was filed. So not all patients go on to take the medication, although these numbers are actually a little bit higher than we've seen in Oregon for whatever reason. The numbers didn't rise very much in the subsequent 2-year reporting period, which is represented by
the numbers on the right here. And I show this just to kind of underscore it's a very small segment of the population that is going to use this, even in places where it's legal. But I think that the cultural impact of this practice really stretches much further than these numbers might otherwise suggest. I think it's discussed more often than it's performed, and it can often serve as a gateway for discussing other ends of life concerns and sort of broader conversations about control over the end of life. And I really think we're seeing how it changes the public conversation about control over dying. My primary methods included 144 semi-structured, in-depth qualitative interviews. All but 3 of these were conducted in person, and almost all of them were audio recorded. I also observed in conferences for Vermont healthcare providers, in public events organized by advocacy organizations, and we see some pictures here of an installation called the Wake Up to Dying Project that took place several summers during my field work that was aimed at fostering broader public conversations about the fact that we all die. So wake up to this fact, right? And they had displays out on the lawn of the library in Burlington, Vermont. And there was also a lawsuit challenging the law that happened during the course of my research, and I observed in those hearings as well to kind of document ongoing challenges to the law. One of the benefits of looking at this phenomenon in a small state like Vermont is that I was able to talk to most of the key players in the state. I interviewed a majority of the prescribers, at least at the time, and many of the key policy stakeholders as well. And the circles on the map indicate places where I did interviews, with larger circles indicating a larger concentration, a higher concentration of interview participants. And I show this just to kind of underscore that I was going all over the state. And this was really important because the phenomenon looked very different in different parts of the state, given the rural nature of Vermont. And I'll get into that a little bit more as we talk about access. So the first narrative that I'm going to examine concerns barriers to accessing medical aid in dying. And the advocacy and media discourse, as I've suggested, tend to suggest that legalizing medical aid in dying ensures choice at the end of life. But the reality is that many patients encounter substantial obstacles to accessing medical aid in dying where it's legal. And I want to share with you a little bit about why this was the case. So this is an overview of some of the barriers that I found in my research that I'm going to talk to you about today. And they include the legislative safeguards, the cost of the medication, finding a physician, access to information, and social support. So we'll start with safeguards. The requirement that patients self-administer the medication was intended to ensure that the act was voluntary. And this is a big part of why we don't, in the US, have the option of physician-administered medication as they do in the Netherlands and Belgium and a few other places. So this proved to be a major hurdle for some patients, especially those with neurological conditions like ALS. And this is because ALS results in progressively declining mobility, and it often entails swallowing difficulties in its final stages. So one of the neurologists that I interviewed lamented, why can't a hospice nurse administer the medicine for the patients if they can't do it themselves? That doesn't make sense to me. It seems like it puts undue stress on my patients, and it also prevents a patient who really needs this program from being able to access it. I feel like it was designed with the cancer patient in mind. And other ALS clinicians expressed similar views that the law seemed to favor patients with cancer, though it's worth noting that some patients with cancer also have swallowing difficulties in the final stages of illness. This requirement tended to encourage patients with ALS and other neurodegenerative disorders to choose to die sooner than they otherwise would have because they wanted to retain the capacity to ingest the medication. And this is one reason why Canada has taken a different approach in authorizing physicians to administer medication. The cost of the medication was also a significant barrier. So this is sort of maybe more familiar in thinking about US healthcare inequalities. The exorbitant cost of Seconal, which was the most common barbiturate prescribed for medical aid in dying, was a significant deterrent for some patients at the time of my research.
And the main reason why it's so high is because in 2015, about a month after California proposed medical aid in dying legislation, the Canadian pharmaceutical company Valiant bought the rights to Sequenol and raised the prices dramatically. Some insurance companies have agreed to pay for it, but others won't, and federal funding, including Medicare, cannot be used for medical aid in dying. Now, since the time of my research, alternative drug protocols have gained in popularity, but physicians' knowledge about these alternatives has been uneven, and many continue to view Sequenol as the safest and most effective choice. So one physician said, it's kind of like a medical frontier, just because it's not done that much. And if they can't afford the more expensive but more effective medication, that doesn't feel right. So that kind of feels like a discriminatory burden. If you're not wealthy, you get the cheap stuff. Probably the biggest barrier that patients face was the ability to identify a physician willing to prescribe for medical aid in dying. And I think things have gotten better over the time that I've been working on this study, but there are definitely still parts of the state where it's very difficult to find a physician willing to prescribe, even though it's legal in the state. The goals of policymakers in Vermont early on was to normalize this practice within normal pathways of care, and especially primary care. They had this idea that everyone could just go to their primary care doctor and ask for this. So there's no state-specific list of willing providers or a Rolodex of willing physicians. But the idea of trying to get people to convince their primary care doctor to prescribe is a bit problematic because there's a primary care shortage in the state, and many patients have nurse practitioners as primary care, and veterans are largely excluded unless they can afford private care due to federal restrictions on VA providers. In general, I would say that access has been easier for patients being treated at the UVM Medical Center, which is the only academic medical center in the state. All hospitals are supposed to have policies to help patients who desire medical aid in dying get linked up with a physician who can help them. But this has not been institutionalized in all of the smaller hospitals. And even at the UVM Medical Center, it didn't always work the way it was supposed to in practice. There's also a very big access problem in the southern part of the state where many patients are actually treated in Vermont at the Dartmouth-Hitchcock Medical Center in New Hampshire. So for patients that are being treated in New Hampshire, their physicians wouldn't be eligible. Additionally, though access has been better around the Burlington metropolitan area, which is the biggest city in the state, I think it's important to underscore that access does not cut along traditional urban-rural lines. And there are a few rural counties that have had a couple of physicians very committed to providing this, where access has been relatively good. And a couple of the larger cities as well just have not had much uptake because there aren't willing physicians. Finally, I would say that social networks really matter for access to physicians, particularly in a small rural state like Vermont. There was a lot of kind of word of mouth information that got transmitted about who might be willing to prescribe. So to return to Margot Hadley, who was the second of the two women whose stories that I opened with, this is what she had to say about the process of trying to find a physician to help her husband. She said, I contacted Compassion and Choices, which is this national organization that helps you access death with dignity. So they said I would just have to find 2 doctors in Vermont to prescribe. So I said, okay, great. Can you tell me what doctors have been prescribing? No, we can't tell you that. So I said, well, how am I supposed to find 2 doctors? I just can't go knocking on their doors. They're not going to meet with me without all of our records being transferred. And I can't do that 30, 40, 50 times. And it turns out that after this conversation with Compassion and Choices, Margot did actually find a physician who was willing to prescribe, in part thanks to her former in-laws who were dear friends of this physician and connected her to this physician. And he had agreed to meet Margot and her husband in his office on a Sunday because he wanted to conceal the visit from the office staff, which gives you a sense of how stigmatized this is. And Margot's husband was so elated. But about a week went by and Margot received a call from the doctor who said that he had changed his mind because he felt that the scrutiny in Vermont had really gone through the ceiling. And he said, I'm so sorry, but people are going to think that you're doctor shopping. And she said, I am doctor shopping. That's exactly what I'm doing. Access gaps were also very difficult for the nurses that were caring for these populations. So I interviewed an oncology nurse practitioner in a part of the state where access has been very constrained. And she was quite distressed about having to navigate this with her patients. And she told me, I think the perception amongst many patients is that it's the law. There must be a way to access it. And she said, it's very nice to have this, but I think you don't have equity. You can use it if you're a patient who meets all the criteria and then is lucky enough to have a primary care physician who knows you and then is willing to participate. Access to medical aid in dying is also shaped by the patient's ability to access information about it. And the clinical standard has really been for physicians to wait for a patient to initiate a discussion of medical aid in dying. And there's lots of good reasons for this. There's a lot of concern that if a physician offers this to a patient, that could harm the relationship. The patient might think that all hope is lost, or that the physician wants the patient to choose this option. So there's been an implicit presumption in the clinical literature, as we can see from these headlines here, that communication about medical aid in dying always begins with a patient's request. So there's lots of attention to how do we respond to these requests. One physician explained the practice like this. I think because it's new and people are sensitive, people pretty much across the board feel that it needs to be a patient-directed question. I don't know of anybody who would put that on the table before somebody asked about it, for two reasons. Number one, the population that's going to ask about this, they're a savvy population. They're people who really want control, they're going to know about it, and they're going to ask. And the people that aren't going to ask may be less likely to be interested. So that's the way that I think about it. So physicians and bioethicists tend to view this practice of waiting for the patient to initiate the discussion as a safeguard to ensure that it's going to be voluntary and that it's not subject to healthcare provider influence. The problem with this is that patients can't ask about it if they don't know about it, right? And survey data from Oregon suggests that public education can lag far behind legislative developments. So because more educated patients are more likely to be informed about medical aid in dying and initiate a conversation about it with a physician, access becomes stratified along socioeconomic lines. It's worth noting as well that this differential access to information could also apply to physicians. And I found that physicians' knowledge of the law and the medication protocols and the requirements really varied as well. So I want to just mention how this played out in a particular case. I met a man named Craig who told me about his friend and neighbor, Ron, whom Craig had helped care for when Ron was dying of cancer. And Ron learned about medical aid in dying from his hospice nurse who had cared for two other patients that utilized Act 39. Ron tried calling his oncologist to ask about it, but she didn't return his phone calls. And at that point, it was too late to find another physician. Ron lamented that he could have used this option if he had started the process sooner. So Craig said to me, I felt like there was two things that were wrong. One was the knowledge that it existed. It was like a secret. And then the other thing I thought was not right was that because apparently his oncologist was not for it, she didn't really pursue it aggressively. So Craig compared this situation to that of abortion, where legal status did not ensure access. It's like the law that you could have an abortion, but you can't find anybody, so you have to go in the alley, right? It's the same idea. Finally, social support was essential for navigating the bureaucratic protocol and assisting with all aspects of the process, including identifying physicians, completing paperwork and forms, picking up the prescription, being an advocate, not to mention helping the patient to plan for death and being present at the time of death, which I'll have more to say about in a few minutes. So one physician prescriber told me about a patient for whom she wrote a prescription for Seconal, but the patient's father could never bring himself to fill it. So as this physician said, they need a good advocate for them if that's what they really want. So just to recap, there are a range of barriers to accessing medical aid in dying in Vermont: safeguards, cost, finding a physician, access to information, and social support. And based on these findings, I've argued that access to medical aid in dying is stratified based on socioeconomic privilege.
And what I mean by this, I think, is nicely summed up by this quote that I'll read for you. The situation is very elitist. Someone has to have the intellectual wherewithal to track down a physician who is willing to prescribe and follow through with that. They have to be able to track down a pharmacy that's willing to dispense the medication, and they have to be able to afford it. And most people who are in the last 6 months of life who meet the criteria to go through with this don't have the resources intellectually, cognitively, emotionally, financially. So it limits it to a very, very small group of people. It seems not fair that way too. And these barriers are not unique to Vermont, so I've just put up a sampling of some headlines that show you some similar issues that have been faced in other states. Okay. So the next narrative I want to tell you about concerns the physician's role in medical aid in dying. And the narrative that I want to challenge here comes primarily from the research literature, which tends to characterize physicians as either starkly for or starkly against medical aid in dying, and consequently tends to portray their involvement in the practice as an all or nothing proposition. And I found a wider range of engagement, which I'll tell you about next. It's a lot of responsibility and power to give people a script that they can end their life with. This statement was uttered by Dr. Alana Reynolds, a hospice and palliative care physician. And she went on to tell me how, as a hospice medical director, she felt the need to take some sort of a stance after the law was passed, yet also support a diverse set of opinions about it because it was such a polarizing issue. She decided that what was most important to her was to truly understand her patients. And after a series of intimate conversations with a few patients, some of which challenged some of her previously held views, she came to the position that she would really support this for the right patient. And I start here because I think Dr. Reynolds' experience was typical, in the sense that many physicians I encountered were not either starkly for or against assisted death in the aftermath of legalization. Instead, they held nuanced and ambivalent feelings that evolved over time through direct experiences with patients. Prior studies of physicians' interactions with medical aid in dying have focused on their willingness to prescribe or how they respond to patients' requests. And what I found is that physicians, nurses, and social workers engaged with medical aid in dying in a variety of ways that extended beyond these options of responding to requests or deciding whether or not to prescribe. And importantly, even if a physician ultimately declined to prescribe, she might participate in other domains of care. So I identified 5 domains of participation in medical aid in dying. Communication entailed exploring the patient's reasons for pursuing medical aid in dying and probing for alternative means of addressing them. In terms of the protocol, providers emphasized that understanding the law was time-consuming and there was quite a lot of bureaucracy that went along with the process. Prescribing, of course, is an obvious component, but it was far from a one-time event of writing a script and often required consultation with other physicians and pharmacies. Providers also often engage deeply in planning for the day of death and in making contingency plans in case things did not go as planned. And finally, several expressed a commitment to educating colleagues about the process, both formally and informally. So I want to tell you about what physicians' participation looked like in a few different cases. Dr. Rhodes had worked as a hospice and palliative care physician for 11 years in a small rural community, and she had been drawn to this area of medicine after experiencing a few significant deaths in her early 20s. She had navigated the Act 39 protocol with 4 patients, 2 of whom ultimately ingested the medication. When it first came up, she was surprised by how ambivalent she felt about it. She viewed prescribing as a tremendous moral and emotional responsibility, and she did not take the decision lightly. Yet she understood the patient's choice and thought it was rational because it reflected the way that he had lived his entire life. She was also committed to non-abandonment and was convinced that if she did not write this prescription, the patient would end his life in a more gruesome manner. And she was convinced of this because he told her he would. So for Dr. Rhodes, the moral and emotional burden of medical aid in dying was a critical part of the practice. It was supposed to stay hard to protect against abuse. She resented those who viewed her participation as a denigration of the physician's professional role and felt that they didn't really understand the thought and care that had gone into this clinical work for her.
So Dr. Rhodes is one of the physicians who really saw this work as a clear departure from ordinary clinical practice. She found it incredibly emotionally consuming, and she did not take her participation lightly. But at the same time, she also considered it a necessary expression of her commitment to non-abandonment. Dr. Jones was also committed to not abandoning her patient, yet this led her in a somewhat different direction than Dr. Rhodes. So Dr. Jones was also a hospice and palliative care physician, and her clinical work had split between primary care and palliative care consultations. When a patient asked her whether she would be willing to prescribe life-ending medication, Dr. Jones felt conflicted. On the one hand, because she strongly believed in the capacity of hospice and palliative care services to provide excellent care for dying patients, she was at least partially inclined to view such requests as a cop-out pursued by patients who had not truly exhausted all of their options. On the other hand, Dr. Jones was committed to the ethos of patient choice, and she did not want to abandon her long-time and very much beloved patient during this difficult time. So ultimately, she decided that the best way to navigate this conflict was to do everything possible to help her patient short of writing the lethal prescription, which she viewed as crossing a moral line in the sand. So she assisted the patient in identifying a physician willing to write the prescription. She agreed to even be the consulting physician, certifying that the patient met the legal requirements. She worked with the prescribing physician to make sure that contingency plans were in place for the day of the patient's death. So she objected to medical aid in dying, but its existence as a legally permissible option made her feel some responsibility to help patients pursue it if they desired it. And this was interesting to me because the dominant public narratives tend to characterize participants as all or nothing. Whereas Dr. Jones found an ethical middle ground that allowed herself to reconcile her opposition to this choice with her deeply felt personal and professional obligation to help her patient receive the kind of care that she wanted. Okay, so my third narrative is about the role of independence and individualism in medical aid in dying. And it's true that people who pursue medical aid in dying tend not to want to be dependent on others for bodily care in the final stages of illness, and that this desire to be independent really does play a big role. But I think that this notion downplays the extent to which medical aid in dying is also a deeply relational practice that requires various forms of support and buy-in from loved ones. So despite the American fixation with independence, people can't actually accomplish assisted death on their own. And this last part of my talk focuses on these social dimensions of medical aid in dying. One of the richest and really most interesting parts of this study for me has been hearing about how people plan and even choreograph their deaths when they have the opportunity to do so. And this is a photograph of Betsy Davis. She was a 42-year-old woman in California who was diagnosed with ALS and chose to die using California's End of Life Options Act in 2016. And she invited friends and loved ones to a 2-day rebirth ceremony, which you can see on this photograph. And she died on the side of a hill as the sun was setting, which was her choice. And to me, this scene really resembles a wedding. We see kind of the tent and the folding white chairs, and people are dressed up. And this, I think, is a pretty extreme example. I didn't encounter anything like this in my data, but there are several elements in Betsy's death story that were commonly present in the deaths that were recounted to me in my research. So we have the presence of close family and friends, a sacred atmosphere, though this could range from party-like to more somber, and ritual elements like a final toast. And then finally, all of these deaths in Vermont took place in a non-medical setting. And the reason for that is because there is a clause of the law that permits hospitals and skilled nursing facilities to prohibit patients from ingesting life-ending medication on their premises. And essentially all of the hospitals in the state have done so. I think there's one continuing care retirement facility that will permit it. So these have to happen at home. Or there have been cases that I've heard about where it's sometimes happening in a long-term residential hotel or something like that.
So I'm going to tell you about 3 patients. The first one is Bennett Tucker. He was a man in his late 70s who had endured a slow decline after a long-term cancer diagnosis. And in his last 2 years, his symptoms had really worsened and his quality of life deteriorated. For years, his wife, Noreen, had dutifully helped him navigate clinical trials and chemotherapy, but bathing, dressing, catheterizing, and moving him had become physically taxing, and she was discouraged that he was not getting better. Noreen felt she would soon need to get full-time nursing care in the home. When Bennett announced that he was ready to take the life-ending medication that they already had on hand. To prepare for his death, Bennett was discharged from a local inpatient hospice facility where he had been admitted for a short-term pain management stay. On his second day home, a physical therapist came to work on his pain, which was a side effect of his bone metastases. And she helped him walk outside to sit on the deck in the sun, which was one of his last wishes. And when he came inside, he got into bed and said to Noreen and his 3 children, "What are you waiting for? Let's do it." And they had expected him to wait another few days and were surprised by this sudden decision. After calling his best friends to say goodbye, Noreen and their children surrounded his bed and they told Bennett they loved him, and his son, who was a physician, left the room to prepare the medication, adding Gatorade for flavor. Bennett drank the mixture quickly, as he had been advised by his physician, and as he swallowed his last few drops, his family told him that they would miss him. He closed his eyes, and Noreen said it was as if he was falling asleep. No gaping mouth, no twitching, no nothing, just really relaxed. And in a matter of minutes, he was gone. This next case was a female patient in her 60s, also with a cancer diagnosis. And she also had a grueling course of cancer treatment for several years before her death. And when the cancer recurred and metastasized, she was quickly drawn to the possibility of a medically assisted death. She had never married, but her life was rich with friendships, meaningful work as an artist and teacher, and a devoted spiritual practice. And her friends surrounded her when she died. Up until the night before she died, she really hadn't made up her mind about what she was going to do. And during the night, she had actually gathered friends in her home because she was thinking about dying that weekend, but hadn't decided. During the night, her intense coughing echoed throughout the house. And finally, she got up at 4 a.m. She grabbed her laptop. She went back to her bedroom to write love letters to friends. And at 6, she emerged and announced to her friends that she announced to her friends that were there in the house that she was ready to go. So while Renee said her goodbyes, 4 friends sat in a circle and prepared the medication with a makeshift ritual ceremony. Using beautiful pottery and sacred chalices, they emptied 100 capsules, which is the number of Seconal capsules required to form a lethal dose. And they sang while they worked and carefully mixed the powder with juice. Then they all piled onto the couch for a final photo shoot. Renee laid across their laps in a favorite leopard print and purple velvet outfit. And then in her signature no-nonsense style, she got into bed and started directing everyone on where to stand. They surrounded her as she drank, chanting softly, and 10 minutes later, she was dead. So I want to share a slightly less positive outcome. And for this one, I'm going to go back to Frances, who's the woman who I started with. And as you probably recall, Frances had ALS. The ALS cases seemed to go a little bit less smoothly because of the swallowing issues later on in the illness. And Frances had been told by her physicians that she had to be able to swallow the applesauce that she would mix the medication into in under 2 minutes. And when I met her a couple of weeks before her death, she actually showed me this bowl that she was practicing with, and she had applesauce cups, and she was timing herself every day to see how much time it would take her to eat this amount of applesauce. And it had been taking 1 minute and 15 seconds, but in her last few days, it was taking 2.5 minutes. So she kind of had a sense that maybe this was not going to go as planned. And I'm going to share a quote now from her physician, who was recounting to me what happened afterwards. I got a call around 5 a.m. from the hospice nurse saying she had fallen asleep and she couldn't swallow it. She got about half of it in and fell asleep, and so she didn't die from that directly. So she took it at around 3. At 5, the hospice nurse called me. The hospice nurse was going out there. I said, start the morphine, and hopefully it has replaced her enough that she'll have respiratory depression. But the hospice nurse was crying. She goes, this isn't how it's supposed to happen. And it was interesting because I didn't feel at all panicked. I was like, that was her path that she tried. It didn't work, but we know what she wants. She wants to be very comfortable. So we'll just start her on the morphine. And if we have to go any higher than 20 milligrams an hour, I'm coming out. As I was going from my house to the hospital, she called and said Frances died. So this is a pretty typical of a bad outcome case. And there are really outlier cases of patients waking up. That's incredibly rare. I don't want to minimize this because this kind of a prolonged death scenario was typically very distressing for the patient, and it could sometimes take longer than the 6 hours that it took Frances to die. But this type of prolonged dying was generally, in my research, and I think generally the data would support this, that this would be the worst case scenario. And even then, most of the caregivers that I interviewed who had experienced this were happy with the outcome because it remained meaningful to them that their loved one got to have the kind of death that they wanted. So I think that these cases all highlight in various ways the fact that medical aid in dying is really an intensely social practice. And this was really surprising to me when I began this work because of the way in which the advocacy narratives really emphasize this desire to be independent. And the deaths that I documented revealed what I saw as a critical disconnect between these advocacy portrayals and the lived experience of medical aid in dying. And so they really showed how medical aid in dying is producing new types of social relationships and dependency around death and end-of-life care. And this is a major theme that I develop in my book. Most caregivers described an intensification of intimate ties around planning for death and around the scene of death itself. So I argue in the book that medical aid in dying remakes sociality, even as it sets about ending life. And this really sticks with the caregivers who live on to tell its stories. However, the role of caregivers' assistance in assisted death remains largely under-acknowledged in the public conversations about medical aid in dying. All right, so to sum up, I hope that I've given you a new perspective on what I see as 3 of the dominant public narratives about medical aid in dying. The dominant access narrative tells us that legalization is the primary hurdle to overcome on the path to medically assisted death. But the reality is that even after legalization, access is not a guarantee. And navigating access can be a frustrating experience for many patients and families. So I think my findings offer a cautionary tale regarding advocacy narratives suggesting that medical aid in dying legislation offers a clear-cut pathway to self-determination at the end of life. Identifying a physician willing to prescribe is often the biggest access barrier. But while physicians are often characterized as either starkly for or against medical aid in dying, the reality is that for many, decisions about whether or not to participate are much more nuanced, and participation itself is not an all or nothing proposition. Finally, one of the strongest public narratives about medical aid in dying is that it is a choice for radical individualism born of a strong desire to avoid being dependent on others for end-of-life care. And while I don't want to dispute the important role of independence and individualism in medical aid in dying, my findings also highlight another dimension that is often left out of the public conversation. And this is that assisted dying is a deeply relational practice with important roles for caregivers and loved ones in witnessing and shepherding death. These dimensions are often overlooked because advocates are concerned about portraying the choice made for medical aid in dying as an independent choice and one that is not subjected to external influence. So I think there are a couple of broader takeaway messages from my research that are relevant even in jurisdictions like South Dakota, where medical aid in dying is not legal. American society has witnessed a surge of interest in attaining control over death in the last decade, but medical aid in dying is just one pathway to such control. We've also seen this desire for control manifest with increasing intentionality about planning one's funeral and burial practices prior to death. and also in the clinical emphasis on advanced care planning. Such control, I think, is oriented towards several things: relieving suffering or avoiding it in the first place, maintaining coherence with one's life as lived so that there's a continuity between the way that one lives one's final days and one's ultimate death, and achieving a subjectively defined good death, one that reflects one's personal, ethical, cultural, and aesthetic values. So the cultural message is that a good death is possible if we plan for it. At the same time, I also think it's important that we think critically about who gets the privilege of planning and examine the cultural values that underlie the expectation for choice at the end of life. And we need to acknowledge that not everyone will die at the end of a long illness that affords the opportunity to plan for one's death. And with that, I think we have time for questions, and I will also remind you before we conclude to complete the evaluation. Thank you. Questions? Yes.
What is a death cafe?
A death cafe is it's an international phenomenon. The purpose of which is to gather over tea and cake. Strictly speaking, it started with tea and cake to talk about death, any aspect of death, and they have them all over the world. I attended several in Vermont that took place in public libraries. They're just open to the community. Anyone can start one. And it's for people that don't know each other to talk about death.
That people are afraid of dying in some process, but will occur in the whole relationship. And I think there's a lot of that that's going on. And I think sometimes people assisted because they don't know what death would be like, but they would know what this would be like.
Absolutely. Absolutely. I mean, one of the things that I found early on in my research is that so I interviewed advocates on both sides, people for and against medical aid in dying, and those who opposed it often had a much greater comfort level with death. It had been sort of something they were exposed to more when they were children, and they had a familiarity with it. And many of those who advocated for medical aid in dying were not up close and personal with death. And I do think there's a fear element there. There are also some that advocate for it that have had really brutal, awful experiences with death. And sometimes that's motivating as well. But I think you're right that many Americans just don't know much about it.
Isolated from it.
Right.
It's not part of our life.
Right. Yes.
So a couple times when we talked about that people chose burden. Am I correct in understanding that?
Yeah, I think that's right.
Okay. So I don't know if you run across this in your research, but do you have thoughts of like what makes people be okay with either being a burden or letting someone else like walk with them at the end of life rather than thinking I'm too much for someone else? Like is hospice care, good palliative care, like supportive friends? I don't know if you read it.
That's a great question. And it's a little bit hard for me to answer in part because my research focused more on those that chose assisted death rather than terminally ill people that might not choose it. So what I think is that the people that ultimately chose medical aid in dying, it was not that they didn't have access to palliative care or hospice. They're all hospice enrolled. In fact, it would be really hard to do this if you're not hospice enrolled, in part because you have to have someone who's going to come pronounce the death after you're gone. They all have lots of family or non-family, but friends support. So it's not that the resources aren't there. I think it's much more kind of almost a personality issue that they just really they want to maintain their control, and they don't want to be dependent on others for certain things as they're declining. And I would say that sort of needing someone to help care for your body, needing help with toileting, those sorts of things, those are really important in their thinking on this issue.
The impact on terms of the beneficiary.
Life insurance, it does not, no. Yeah, it's not classified as suicide for that reason. Yeah.
They say
Right. I mean, so I was doing this research in Vermont, which is 99% white or something like that. So I couldn't really explore the racial issues there. But elsewhere in the US, the people that have used this, they tend to be white, dominantly white. And I think there are questions there about why that is. I think the assumption is often that that's a matter of preference. And the point that I've tried to make in some of my work is that we don't actually know if that's a preference issue or an access issue.
I read this.
Please do.
I'm Father Zimmer. I was the priest here at this hospital. Saying no, we can't do this. Well, church doesn't. Or a system. Reason. There, well, we're not for this. Question of makes us human. Is a human being. We want to be loved. That's someone who says so. Just wanted to that question of do I make myself? Am I making myself? I would almost say.
Well, I'm grateful for those comments and for that perspective. And I'm really glad that you brought up the issue of dying well, because I think that this project kind of raises questions about what does it mean to die well. And I definitely don't want to give the impression that, I mean, I haven't really talked about my own views on this, but I do have a lot of ambivalence about assisted death, and I don't think this is the only way to die well. And I do think that there is something worrisome about thinking that sort of dying in this very sanitized way, where there's control of bodily fluids and sort of making sure that things don't get too dirty. I mean, that I think says something about our culture that maybe is not so great. But what I think is helpful about this example is for people to be able to think about, well, what might it mean to me to die well?
Well, that sounds so good.
I'm just gonna grab the microphone quick. The audience online is having trouble hearing the questions.
Okay, I'll start with you and I can repeat the question.
Okay, thanks.
I'm also a healthcare nurse, and I would just like to not agree with this, but the one thing that they could agree with is people aren't dying. It's in a situation like this, you're not dying alone, which is dying well, I feel. And also, I have the experience of a dear physician friend who committed suicide. He hung himself because he was diagnosed with a brain tumor. He did not want to be a burden to his children. And, you know, it was early in the diagnosis, didn't do any treatments or anything, but I don't know if he would have chosen something like this if it would have been more accessible to, even as a physician.
Yeah, I mean, those stories are part of what are the kinds of narratives that helped this legislation pass in the first instance in Vermont and in other states too. These stories about these sort of more gruesome suicides, really, and is there a more humane way to do that? It is part of the questions that were raised. Yes.
I'm just gonna take saying in the sense that even like a normal natural death is a taboo public topic, right? Say like talk turkey, like this should be the conversation. And so then bringing up something that's even more like kind of controversial, like made is hard, right? So I think the next question for us as providers when patients bring this up is always tell me more about why you're thinking about this. Like, is there an unmet need and we can meet that need, or we can talk more about what we anticipate this trajectory and have a plan B and have a plan A and then a plan B and all of those things. And I know that all of this work is being done prior to these patients, like getting to the point where they actually have the medication in hand. And so I think that we all just as South Dakotans and as Americans in general, death has been so institutionalized. It's so removed from our daily life, unless you're fortunate enough to work in palliative medicine like myself, where we're talking about it all the time and it's normal. But I have patients say to me every day, it's so easy for me to have these conversations with you. Why is it so hard to talk about them with people that I love? And so to kind of get to where you were going with why don't people trust that the people that love them want to walk alongside them? Because they're vulnerable in a way that they don't know if they're going to lose the ability to act for themselves or the ability to think and know and not control their physical body. And it's just such an interesting and sacred space to be able to be in with person. So I just appreciate you so much for coming and speaking to us. I thought your presentation was wonderful. And then one last question that I have is, I have no idea it was 100 capsules of the barbiturate. Do you have any idea what the out-of-pocket cost is for patients for the cocktail?
So for the Secanol, it was $3,000 for a while. I think that is no longer the cocktail of choice for that reason. And there's another cocktail that has become the preferred one, which I'm not going to be able to remember what it is. I think it's 3 things together, and I think that one is $500.
We have time for one more question.
That's okay. Do you have you seen, I don't know this, but the correlation between more emphasis on quality of life rather than saying my life has dignity, no matter if I'm able to do all these things for myself? But like placing my worth in what I do rather than placing my worth in.
Mm-hmm.
You see a correlation in that in these studies?
So another great question. I don't know that, again, because my sample is kind of biased more toward people that have wanted to choose assisted death, but I would say that that population, I do think that there is an orientation more toward doing than being, right? And sort of what can I still, what activities can I still do? What cognitive faculties do I still have? So yes, absolutely. I think that is a big piece of what's happening here.
Thank you so much. We have one last thing to do that Dr. Hastings is going to, everyone who gave us an email address, their name has been put in a, I don't know what that is actually. And
We'll call it
a bag. And someone will get one of Dr. Buchbinder's books to take home.
You're gonna drop.
But thank you so much, Dr. Buchbinder. That was an amazing talk, and it was wonderful to have you here.
Thank you all for being here, especially at this late hour. I really appreciate it.
No, she's not gonna drop out. She made the slips of paper, so. Thank you. Okay, so I've drawn a name out. Is Sarah Dvorak. You win for asking great questions. Thank you all so very much for coming.
I have 5 different